What's up, everybody? Dr. Bonzo back with a late night edition of another bombastic review of a medical topic in 5 minutes or less. It's real late, so let's just jump right to it. Tonight's topic is on migraine headaches. So the International Classification of Headache Disorders defines migraines very specifically. You have to have at least 5 attacks, lasting anywhere from 4 to 72 hours if you don't treat them, and they have to have very specific qualities. So they have to have at least 2 of the following: either a unilateral distribution, so one-sided or the other, pulsating or a throbbing quality. They have to have a moderate to severe intensity, so at least about a 5 out of 10 or higher on your pain score. And they also have to stop you from doing what you're doing. So you can't exert yourself, you can't continue working, you have to stop, go lay down in a dark room, something like that. So in addition to having any of those 2 things, you also have to have at least one associated symptom: nausea, vomiting, photophobia, phonophobia. Those words literally mean fear of light, fear of sound. But pretty much normal light, normal sound will severely worsen headaches in people who have migraines. Now, if you remember in our previous video about combined hormone contraception, we talked about migraine headaches with aura being an absolute contraindication or reason you can't use estrogen-containing birth control because of the risk of stroke. So an aura is when you have this preceding kind of syndrome, prodrome, that happens where you have a sensory disturbance before you get your headache. So you can feel it coming. So things like pins and needles on the face, numbness, trouble getting words out, loss of vision, seeing spots, those things will happen anywhere from 5 minutes to 60 minutes before your headache starts. So other things to think about in terms of classification, since we talked about migraine with aura, is the difference between episodic and chronic headaches. So episodic headaches happen anywhere from 14 days, in other words, about 2 weeks total of days per month or less. Chronic is what we call it when you start to have headaches for 15 days or more in a given month. So think about half the days of a month or more. That's when we consider it chronic headaches, chronic migraine headaches. The reason why that's a big deal is because once you start taking medicines 14, 15 days out of a month, you are at increased risk for analgesic rebound headaches. So you can actually start to get migraine headaches because you're withdrawing from the medicine, even if you're using non-opioid medicines. So what are these medicines that we treat migraines with? Let's get to that. So there's abortive therapy and there's prophylactic therapy. Abortive therapy is what we give people when they get a headache. We're trying to make the headache go away. And these are easy to remember. It's 2 big things to remember. If somebody has a mild headache, just use an over-the-counter NSAID, naproxen, ibuprofen, something like that. If they're having a more severe headache, use a prescription triptan medicine. So any of those prescriptions that end in the word triptan, sumatriptan, frovatriptan, whatever. Now, that's for abortive therapy if they get a headache. What about prevention? Well, anybody who has more than 3 headaches a month is a candidate for prophylaxis, or a pill you take every day to prevent the headaches. And also anybody who just has really debilitating headaches or just says, this is too many headaches for my lifestyle. The reason why they love to ask about this a lot on tests is because they, about 1/3 of people who have migraine headaches are eligible for prophylaxis, but only about 10% of them are actually taking it or offered it. We do a terrible job of remembering to give people prophylaxis. First-line prophylactic agents include topiramate, which is Topamax. Main side effect of that is weight loss, and also some people get paresthesias of their fingers, so kind of this weird numbness and tingling or loss of sensation in their fingertips. Other first-line agents include valproic acid, which is Depakote, and also non-selective beta blockers. So beta blockers that block your beta-1 and beta-2 receptors, things like timolol and propranolol, work great. There's also a beta-1 selective blocker, metoprolol, which works very well also. Side note about propranolol, the non-selective one I mentioned, we can also use it in children because it comes as a little itty-bitty 10 milligram pill. We're used to that 40 to 80 milligram dose. It comes as a 10 milligram pill that you can use in most kids as long as their blood pressure and pulse isn't too low. And speaking of kids, one other medicine that we use for prophylaxis in kids sometimes is cyproheptadine or periactin. That's an old school antihistamine that works okay. So other things to think about as far as second-line agents for prophylaxis includes things like gabapentin or Neurontin, amitriptyline, which is Elavil or an old TCA or tricyclic antidepressant medicine, and also riboflavin, which is vitamin B2 at high doses, like 400 milligrams a day, works pretty well for people who don't like prescriptions. There are these newer calcitonin receptor antagonists that work pretty well. Nurtec is the oral one that you can use for abortive therapy, but it's like $900 for 8 pills. And there's also Emgality, which is a once-a-month injection that works pretty well also, but it's like $600 for that one injection per month. So in summary, migraine headaches, having at least 5 attacks of headaches lasting anywhere from 4 hours to 3 days, having 2 of those qualities, one-sided, throbbing, severe, moderate to severe nature, interferes with activity, and also one associated symptom, nausea, vomiting, photophobia, phonophobia. We know about abortive therapy, NSAIDs for mild cases, triptans for more severe cases, and prophylaxis. Don't forget your non-selective beta blockers, topiramate, and valproic acid. All right, 5 minutes is up.